Assalamu alaikum, everyone. Today, inshallah, we're gonna do the knee pain, which is like a resistant cause of pain. When we go to many therapists, sometimes it's still there. Sometimes we do the surgery, it's still there, and it still hurts. And subhanallah, we use it in every kind uh, of our daily life with these things. I'm gonna ask to. Oh, okay, so for the knee pain, I receive most of my clients because they have resistant knee pain that did not get solved after surgery, after arthroscope, after acupuncture, hijama, or exercises and stretches, and they come seeking help, and they can go nowhere with their knee pain going there. So what we're gonna cover today is first we have to know what's the red flags that we have to stop and pause when they happen. What is the mechanical compression and how does it work on our knees? What do we need to know in terms of anatomy and other things that we did not study in medical schools for those who are doctors? And then we're going to take a home message at the last 10 minutes. I'm going to pause. I'm going to stop the recording and I'm going to open the time for questions and answers, inshallah, for everyone. So for as everyone, we just do general assessment first. So we have to have the history from this person. This history will cover personal history. How were they born? Did they have problems in their childhood? Have they ever have like growing pains, any problems in the hip, back, and all that? Surgeries, if they have ever done surgeries, or car accidents, if they had any traumas, any fights, family history for joint and autoimmune disease. So many autoimmune diseases, like for example, inflammatory bowel disease can present with knee pain. Rheumatoid arthritis can represent with knee pain. So many things can represent elsewhere other than the joint, but the joint can manifest somewhere. We're going to see fascial inclination. What does this means is we see if there is specific posture, like if the knees are knocking, they're far apart, is the leg is straight, is there any problem with the gait, we do assessments for range of motion, all these kind of things. And if we have any imaging check that they did, like MRI, CT scan, if they had a TAP, especially teenagers, 15 to 25 years old, sometimes sexually transmitted disease can present with knee pain, and sometimes septic arthritis can be a cause of knee pain. So you have to eliminate those things before we try to work and solve the problem. Once we also have to assess the tissue and the scars around the knee, in the back, front and back. We have to see if there is any scars even elsewhere that can affect our problem here. Why is that? We are going to know that in a few minutes, inshallah. After we figure out all these 4 steps, we create a program. Usually this procedure takes about 40 minutes to 1 hour sometimes. And in some cases, it takes 1.5 hours in order to go for this general assessment. So don't be shy to, like, if you have a business, to charge your client for this general assessment and creating a program, because it's time consuming and it's gonna pay off with the long run, growing away from this pain. Um, Anybody familiar with these things over here? This is the way we have to assess the client. Best to have them in clothing first and see how the arms are lining. We have to see if both shoulders are at the same plane. We have to see if the head is shifted to one line versus the other, if there is any pull on one side more than the other, like even those 2 lines have to be equal. Sometimes we find a crease on one side, the other one is not. Sometimes this abdominal muscles are so sagging and coming down, especially in obese people. We have to see the lines of the knees if they are far apart, if they are knocking knees, and we have to assess the patient when he's walking. So we do the gait, straight walk and then heel walk and then tiptoe. This is very important to know where to find our problem. Then with the back, we are going to see, it's best to see the back as it is. We mostly see it when people lie on the bed. This, and then we can see scars, we can see protrusion of one scapula versus the other, we can see if there is any curvature of the spine, like, kyphosis, scoliosis, lordosis, anything like that. We are going to also look at the sidelines. We're going to see of any myofascial adhesions. I have a little bit of a picture to show you things that we assess. We see if there is a specific like if they're in pain holding this position. This is another thing to assess. And then we are going to do to assess the arms. Sometimes the arm, one of them is further away from the other, and it's very hard for them to line them up. The forward posture of the head, like I'm gonna actually use a pen to show you how it is. So usually sometimes the head is curved to the front like that, especially with texting heads, teenagers. They usually have this problem. So we need to assess if there is like a problem with the neck area as well. We have to assess if there is a hump on this area. We have to assess if there is, like, anything that is outside has to be assessed. We have to have this picture in our office. Try to mark the areas that are of a problem area for yourself. It's very important to know our red flags and our limitations. For those who are not doctors, you have to know that we have to differentiate between bone pain from joint pain, because it can be metastasis, sometimes it's a tumor, sometimes it's infection, sometimes it's neurological. So I prefer to have an MD consult before I do see these people, and usually they come after the MD consult. When they say, for example, young people usually have a query arthritis. It doesn't show in an X-ray, it doesn't show in an MRI, it doesn't show in anything. Okay, so this is where I think our therapy is gonna work with them. So for you, whoever want to answer one of these questions, I do ask these for my clients. Sometimes they say, "Oh, we did chiropractor, we did physiotherapy, we did everything, and it doesn't work." And I say, "How many times did you go? Did you have a plan with them?" And they say, "No, we went once." So very important to know if people want an abracadabra approach, like, magic approach. I'm gonna just, like, point the stick and have this problem solved. I'll ask them if they had 1 or 2 years therapy in one of the therapists, what areas they usually target. Very sadly, most people will say it's only the knee, sometimes a little bit of the hip is targeted, sometimes is a little bit of the leg targeted, but they don't move outside these areas. So no wonder it's not working, and we're gonna know why after a bit. How many sessions did you do? Some people went for 2 years, 3 sessions a week. So sometimes it's so many sessions that they've done before, and when they come try your therapy, they want to come for a week or two. So you have to also tackle this part before you start. In order to prevent frustrations, you have to have this, like, how many sessions are we going to need with your situation? And for sure, we're not giving promises, because healing comes only from Allah. So you are going to say how system works, and also we're gonna do this. Okay, so this is fascial connections. Like, do you know what the fascial connections of the knee? Anybody can, like, say if they have a knowledge about the fascia? How many myofascial lines will cross the knee? Do you know? Anybody wants to answer? Okay, so this we are going to know in a bit as well. Okay, so we're gonna do the assessment head to toe. We're gonna take history. As we said, we are going to cover the nutrients. So many people have a problem with nutrients, okay? Like they don't get enough nutrients for our joints. What does our joint needs? It needs water. It needs glucosamine, chondroitin sulfate. It needs collagen. It needs a lot of water and movement, okay? We need to do stretches. We need to assess functionality. Sometimes people don't worry about the function, they worry only about the pain. Our approach carries function and pain, both of them together. Okay. So if the pain doesn't go away um, like quickly, we have to assess the function in each and every session. If we find we're going nowhere, then that means we are doing something wrong, right? So this is the knee joint, like very, very simple diagram for those who are not doctors. There are meniscus in the knee. This is a cartilage or something that looks like your nose, like the wiggly part of your nose. It's meniscus, and it's between the two bones, provides a cushion for these bones to jump, climb stairs, uh, walk, and it's just like, prevents these two edges of the bone to like, do friction to each other. The cartilage, this one over here that lines the bone, is also, it's called articular cartilage, and it provides a smooth surface so the bone doesn't also attack each other and cause pain. And then there are ligaments, or like, tissue that holds the bone with each other on both sides, and then there are muscles. All of these are like held by a membrane that is very, very like, vascular. It's very sensitive. It allows nerves and blood vessels to go through in and out. And I just want you to have this picture in mind because we're going to use it pretty soon. Imagine if this tissue is not that big. It is very, very short. Getting the bones close to each other, it's going to cause pain. It's going to squish this down. It's going to start eating these up. This is how arthritis starts. This is a little bit more information about what's happening inside the joint. You can see these things are called cruciate ligaments, anterior and posterior cruciate ligaments. These get torn in accidents, falls, playing soccer, sports, and all these kind of things. These are called meniscus. So for people who experience meniscal tear, so if you hear these things, you're going to be familiar with. And this is inside the joint itself. You're going to have the patella here, which is a little bone that glides on top of the knee joint. So it's not inside the joint, and it has its own specific problems as well sometimes. Uh, Another picture over here, you can see the knee from outside, how the muscles go far up till the hip. And you can see this one hooks to the outside, this one hooks to the inside over here. You have all the way down here. So if I'm only working here, I didn't tackle these ones. Like, what if this is pulling? What if this is pulling? Like we have to know how many muscles there, where is the pain of this person, what initiated this pain, how did it start, what positions make this person ease out of pain. These are another connection, like, people with, for example, high heels. This is the back of of everybody's leg, and this is the heel. So you can see this muscle holds both sides of the knee. So imagine if this person is having high heels. So this one is always going to have about 5-7 centimeters shortened for a longer time period. The longer I wear the high heel, the longer this muscle is going to be shortened, and taken in consideration that it's going to stay short like this. This is the sitting bone. This is the bone that we sit on. And this is the muscles at the back of our leg. This is what we are sitting. For those who are sitting right now, we are sitting on those muscles. So people who drive for a very long time, they actually get these muscles also shortened. And what's the problem with this muscle over here is we have the sciatic nerve coming in between this muscle. It's also supplying these muscles. And this bone over here, when it's always in the sitting position, like I had a video about 10 minutes saying how sitting kills us. Okay, especially sitting on a chair for a very long time. People who work from home, people who are government workers, people who are driving trucks, taxis, Uber, all these kind of people, they do come with knee problems. And imagine they have the therapy on the knee and the problem is not even there. This is a person. Like I didn't have a permission from my clients to share a picture, so I wanted to share this one. It's available online. So you can see so many problems with this person's back. When we do the assessment, and I see like here, you can see the skin is denting inside, sticking to the bone. Here it's denting inside. It's like grooves. These we call my facial adhesions. This is one thing. The other thing, if you follow the spine line from the neck down, you're going to find there is a slightly of curvature over here and here. So this person is going to experience pain somewhere else. He's going to experience probably low back pain, probably hip pain, and probably knee pain. It depends on which area is the most vulnerable with this person. And if I start working on the knee because the pain is here, I didn't tackle this area over here, the problem is going to still be there because there is unequal pressure from the right side rather than the left side. So the assessment, even his right shoulder, you can see is slanting more than his left shoulder. For these particular people, I need them to go and do an assessment at a chiropractor. He does something called bioimpedance analysis that they experience. They tell them, oh, this one is like, for example, 5 degrees to the right. This one is having a little bit of arthrosis, and this one is blah, blah, blah. So they get the assessment report, and I work together with the chiropractor. We do like bracing, we do stuff like that, and then this thing gets fixed. And guess what? On the way, you will also lose weight because people who take a lot of painkillers tend to have some water retention in their body because of the stress their body hold against pain. They tend to eat more because NSAIDs and anti-inflammatory cause a little bit of gastric irritation, so they feel hungry more than normal. And sometimes they use stress eating to eat and forget about their pain. So they usually are of more like heavy weight. And I have a lot of people that I was just treating for pain and they lost a good amount of weight that they were so happy that the therapy tackled both body weight and pain together. And of course, pain management or pain sensation is decreased when the body weight is less. So this is an example of somebody that had a problem, and you can see how many things did we see only by looking at his back. Okay, this is a video for fascia for those who asked about fascia. And like, you know, this guy, this is how we feel fascia. I want you to try to do your fingers just like him, his Thomas Mayers. He has a lot of courses available online. I took some of his courses and he's working with the fascia with his fingers, with his arms, with his hand, and he has a very nice technique of showing things. So for whoever is having knee pain, please follow along with him and tell me how it is, and then we're gonna do a little bit of a video for the fascia afterwards. Okay, let's go. It's only a 3 minutes video.
When you are doing this, the same thing applies as when you were doing the crural fascia, when we were doing this with a big sweep, because I have to get down pretty close in order to be able to use my chest muscles with the work that I'm doing, rather than being up here and trying to do it with my arm muscles, which if you're vibrating, you're not doing it correctly. However, there is a way to make this a little bit easier. Let me show you. This gives you the opportunity to either work in and out with the tissue, and also for her to work with the tissue. Go up on the balls of your feet, lift your heel up. That's good. Go down now. Put the heel down, lift the front of their foot up, and then put the front of the foot down, lift the heel up. And in this way, I can work again up the outside, down the inside, up the inside, down the outside, whatever direction I'm going, but I do it by working against the restraint of the yoga belt. And that makes life a little easier. Otherwise, you really do want to get down close. We can do this also, stabilizing the foot with my third hand. I can go just inside the shin bone. You see how I'm finding the shin bone and just going just inside, finding the fibula bone and going just behind, just inside of it. And now, in between my hands, I have that deep posterior compartment. So now, heel up, heel down. Good. Heel up, heel down. That's good. Okay, so just so you can see the inside hand, I want to show you I'm really not just going anywhere behind the tibia. I'm going to the back side of the tibia. It makes a difference how precise you are. So really right behind the tibia, right behind. I'm getting hold of that and getting hold of its opposite on the outside. And now, without the yoga belt, I'm just using my hands. That's right. Just lift the heel and drop the heel. Lift the heel and drop the heel. Lift the heel and drop the
So you can see how many tissues did he go through. So this is, so for example, this is one of the myofascial connections of the knee. I'm going to show you how this connects our body muscles together from head to toe, and how something in our neck can be affecting our knee over here. Never mind the things we studied in medicine, like, nerves, the spinal column, all these tracks going down and up. We are talking about fascia that we can see and feel by ultrasound and by our fingers and by our assessments. So this is an example of one of the muscle connections. All the lines have these muscles spotted and mentioned, so you can actually tackle them. And I have a little bit of videos to show you how they do the assessment for specific lines and how they explain it as well. So if we start with this one, this is called superficial backline, and it connects between the gallia aponeurosis, the one that's on the top of our head over here, that is connecting to the front. It's called occipitofrontalis muscles, that we can raise our eyebrows in the front of our head, holding all the way back to the posterior hairline over here, holding all our cervical spine back to our erector spiny muscles. These are the muscles that erect our spine or keep them straight, holding to the sacrotuberous ligaments over here, and then thoracolumbar fascia, holding to our hamstrings, right? And then to the sides of the knee. And then from the sides of the knee, they are holding to the gastrocnemius, which is these muscles, back to tendo Achilles, and all the way to the bottom of the foot, for the plantar fascia and shoulder flexors. So sometimes even flat foot can cause knee pain. Sometimes sacrotuberous ligament problems or a sciatic nerve problem can present with knee problem. Sometimes it's back muscle problem over here. Anywhere over here that somebody experienced surgery can have a scar that pulls on this line and experience this knee pain. Okay, in medicine, we only studied a little bit of referred pain things in certain diseases, but it didn't cover the whole fascial system. And it's very important to know where am I going with that. Like for a person who is sitting for a long time, is always in the computer, they have like a texting neck. I have to work all this line all the way from his head all the way down to the bottom of the feet. Why? Because this is his problem with knee pain. And most of people who work on the knee pain, they don't go to the back because of the inconvenience. They just go to the front, tackle the front. They don't go up, they don't go down. So it is incomplete business, right? This is another illustration of the fascia. It's a very, very important for you to watch, especially, and it's very, very short. It's about like 2-3 minutes, okay? So please focus and have any question prepared for the last 10 minutes, where we are going to stop the recording and open it up for questions and answers, inshallah.
Hi, I'm Tom Myers. Welcome to Anatomy Trains. Anatomy Trains is a revolutionary new understanding of how the muscles connect through the fascial fabric of the body. In a way, it's similar to kinetic chains you might have heard about. It's also similar to the meridians in acupuncture, but Anatomy Trains is based wholly on Western anatomical understanding. It's a new, clear map of the direct force transmission through the fascial fabric of the body.
This is very important for people who were in medical school. Like, remember this fascia that we were throwing in the garbage? This is actually what we are working on right now.
Clear map of the direct force transmission.
Can you see
through
this?
the fascial
So
fabric.
this is the force transmission between different muscle fibers that will experience the pulling from one region to another just because of this fascial connection. So everyone who cooks or who did a dissection before, they will be familiar with that. Can you see?
Fascia is what used to be called sinews, the sheets and strings of connective tissue, the white gristly stuff that holds us together. It's the stuff that envelops the muscles and attaches them down onto the bones. And although the fascia permeates the whole body with a network through the organs, the brain, the lungs, and everywhere else, this Anatomy Trains map focuses on the direction of this fabric through the muscles. Force is transmitted from muscle.
Just imagine that this fascia transmits blood vessels, nerves, nutrients, and interstitial fluid. This fascia has been linked to cancer, autoimmune disease, and pain. And these are the three things we have shortage in covering in medicine. For autoimmune disease, we get immune suppressants. For pain, we give painkillers. And for cancer, we do chemotherapy. So there is a lot of research paper. There is a lot of videos. For those who are interested, just drop a line, and I'm gonna send you videos to learn more about the fascia, see how we diagnose it, and see how much it is connected. Most people who are studying fascia, they are studying it in linkage to movements. For me, I do fascial connection with functionality, like I do for organs, I do for autoimmune disease and stuff like that, not only kinetic. Okay, for this purpose of the lecture, please focus for the rest of this, just 2 more minutes.
Muscle via this fabric, and that creates the postural and movement limitations we see in our practice every day.
Can you see this? So this guy, this is superficial front line, and this is superficial back line. So he found the curvatures that need to be adjusted and that can cause this person's pain. So, for example, so he found that the neck to the solar plexus over here is short and down. So because his neck is texting neck, so it's going down. So in this area, he will probably have a problem in his temporomandibular joint over here. That is supplied by the trigeminal nerve that is connected to the trigeminal nucleus over here in the cervical area, and that can affect his balance. This is like, it's a very big thing that people have businesses run only of this part of the body. Only from temporomandibular joint adjustment, they can adjust the whole front line and even knee pain and gait problem.
The whole connective tissue matrix is one single net. All the divisions that you find in the books and even the Anatomy Trains themselves that you're...
Can you see that? This is how he dissected the body. So he took the muscles with the fascial connections without throwing this fascia in the garbage, and he connected them, and then he stated which muscles are connected together and how they affect the functionality.
What to see here, they're all made with a knife from this single indivisible whole net. Please remember that as we start looking at all these parts. The whole is real. Any division is conceptual. The fascia has a grain, just like fabric or wood, and we'll be tracing the grain of the fascia, which makes sense out of this bag of muscle tissue that we all live with. Muscle without fascia is just a hamburger.
So he says that muscle without fascia is just a hamburger. They're not going to have the strength of movement. They're not going to have their blood supply. They're not going to have their nerves going to them. So it's very, very important to know the fascia, because even if you give up muscle relaxants with a tight fascia, the pain is not going to go away.
In our fascial net makes sensible movements, unless, of course, it's too short, or too stuck, or too weak. Here's the news. Books tell us that the muscles just attach to bone, but the muscles also connect to other muscles through the fascia. Look, the rhomboids are being pulled under the scapula by the serratus anterior, as they do when you put somebody's arm behind.
Can you see how hydrated is the fascia? Fascia is affected with three things. Three things can injure our fascia: trauma, that can be surgical trauma, it can be emotional trauma, it can be accidents, it can be falls, also dehydration and stress. So these three things are the enemies of our fascia. So stress, trauma, and dehydration. These are all affecting the fascia. They cause the fascia to be stuck somewhere and then initiate a pain, initiate an autoimmune disease, or start a cancer.
Back. And this happens all over the body, as you'll see. It's this muscles attached to muscles idea that really leads to the new treatment strategies you'll learn in anatomy trains.
They actually created forces over here. They did ultrasound in other places in the fascial lines, and they monitored how the fascia is connected by acupuncture, by electrodes, by all these things. So these are all studies made by Harvard University.
Dissecting out these anatomy trains involves one simple change in approach. We turn the scalpel sideways. Instead of cutting out each muscle, we come to the attachment, we slide the scalpel sideways under the attachment and maintain the fascial connection. To the attachment, we slide the scalpel sideways under the attachment and maintain the fascial connection. We slide the scalpel sideways under out each muscle.
So I wanted to point this up because some people will have a problem with their, for example, elbow. And they had a broken finger before that is like healed in a wrong way. And this is the cause of this elbow problem. When they come, they say their physiotherapist, their chiropractor, or whatever, just work in the elbow area, only here. She's going to work only on the biceps, only on the common flexor origin or anything like that. They're going to do 12, 24 sessions in this area and the problem is not solved. And you look, there is a scar here and this is the pull is coming from here. So it's very, very important to follow how those, this is the trapezius, this is the muscle connecting our back of the head to the half of our back almost, and going to our shoulder. This is our deltoid or Popeye's muscle. And this is the intermuscular septum that comes near to the biceps. And these are the muscles who affect our wrist joint and our fingers. Okay? They're all one sheet.
To the attachment, we slide the scalpel sideways under the attachment and maintain the fascial connection from one muscle to the other. They've been there forever. It just took until the 21st century for us to see.
Can you see this one? This is the subscapularis over here. These are the rhomboids. And he's just like, showing us how the whole sheet is continuous. It's a continuum of muscles. It's not only one muscle. That's why, like, I had my left arm broken, about a couple of months ago, and I was able to move it completely. The doctor was so surprised, and he said, "How?" But the muscular system around was able to move my arm, even though the bone was broken. So I told him, just forget whatever you studied in medicine and just see the MRI, the X-ray, and the ultrasound and fix it. So our function shouldn't rely on one single muscle getting broken or getting diseased. Until we fix it, we can do things to have the muscles around it have the job instead of it.
How muscles work as a system, the myofascial meridians. So, maintain a consistent fiber direction and maintain the fascia connection between the muscles, and voila, we have an anatomy train. You're about to benefit from seeing the connected, meaningful, functional units that surround and position the skeleton in the continual dance of life.
So this guy, he has a book. It's called Anatomy Trains. It's a very, very nice book. You can look, he covers it from the embryology life until, and how this fascial lines came since we were in an embryo. It's very, very interesting book. And I think one of my classmates and students, she actually have the book in a PDF format. So if anybody wants to have a look, they can do that. One, we have about 10 minutes, and then we are going to open question and answer. We are going to see like some my facial lines connection that you can see over here. Also, like it's a very short video, but it's going to show you something that is nice. So this line here, you can see it's passing in this area. Most people who have C-section, they have appendectomy, this will actually affect also their knee problem. Like some people will experience knee problem after their C-section. So you have to examine this line. Just see where the lines are going, spot scars, and see where the scars are, and then try to figure out which line is affected. And then we start to tackle this by stretches, by anything that we can actually do. This is another functional line that mostly affected in people who sit for a long time. Their arms are usually down, so this is going to be shortened. They are pressing on these things, so they're going to experience low back problems, hip problems, arm problems, shoulder problems, all these kind of things. Just try to see how you can relate these lines to our daily life. This line is connected to sternalis muscle that we never studied in medicine. It's going to be nice for people to figure it out. I didn't put the picture here, but I might, if we have time, I will show it to you in my book. I will have 2 book recommendations to you by the end of this session, inshallah. And you can get them off Amazon or off anything. You can find the PDF format sometimes if you're lucky. So they are going to be a very good reference for you, inshallah, at the end of this lecture. You can see texting, like, shorten this line all the way here. I'm gonna stop this video and go to the next video so you can have some one of the lines explained to you completely, and it's gonna make a lot of sense for you after this to create your own plan and know what's stopping your knee from getting better. So we're gonna do the superficial backline over here because it's a very thorough explanation, and I think more than half of my clients actually have this problem over here. So let's get started.
Hello, I'm Dr. Brian Abelson from Kinetic Health. Today we're going to talk about fascial planes. Something I actually wanted to make a video on for a while. And this is a really interesting subject. It's something that crosses over into many different fields. And it's all about kinetic chain relationships and about fascial planes, about how one area of tissue interconnects with the next, and how this affects our anatomy, the injuries we have, how we can have an injury in one area, and yet the restriction in an area maybe far away from that is causing your problem. So I think you'll enjoy this particular rendition of the taping we're doing today, because we're going to discuss some really interesting things. We're going to start with what we call the superficial back line. And I'm going to get my partner, Evangelos, to come in, and he's going to go in. Dr. Mialonis is going to tape the bottom of the foot all the way back up to the top of the head. And then we're going to work on what we call the superficial front line. Now, while we're going through this, I really want to make a point here that this information is coming from a wide variety of researchers, from Thomas Myers, from Anatomy Trains, from the Stuccos in Italy. They've done some amazing research in dissection. So these aren't theoretical structures. These are actual things where they go into the anatomy lab and they basically do dissection, and then they see these interconnections. After we do that, we're going to talk about some of the relationships with acupuncture. It's very, very interesting when you look at acupuncture because they have very specific points on what they call meridians or lines of energy in terms of the Chinese philosophy of how this particular form of therapy works. And then they have specific points on those lines. Well, it's interesting that if we look at the correlation between where these lines and meridians are located, they're exactly on the fascial planes. So after the taping, I'm going to mark a few points in there, and then we'll sort of show you some of the correlations between these different types of therapies.
Hello, Dr. Evangelos Mialonis. What I'll be demonstrating now is the superficial back line, and I'll be taping it along the back here on Thara so that you'll get a visual of the fascial plane, this part of the kinetic chain. So once again, it's the superficial back line. Back line. We're going to start at the bottom of the foot. And so it starts out in the plantar fascia and the deep short flexors of the foot. So it's penetrating different layers, superficial and deep. The fibers wrap up and they encompass the heel, tying right into the Achilles tendon. It's a very strong connection. And then that follows right up into the soleus, which is the deep muscle of the calf, fanning out to the sides, and then into a more superficial layer called the gastrocnemius. So remember, this is one continuous connection. Even though we're breaking it down into different anatomical parts, you have to think of the fascia as a continuous plane all the way up and encompassing the body front and back into the sides.
You have to think about that like the Spider-Man suit, like socks, like as if we are in a jumper suit. All of this is a continuity, okay? So this is how we should think about that.
And when we follow it from the calf, from the soleus and gastrocnemius, the superficial back line travels up into the hamstrings. And the hamstrings, very strong connection. The hamstrings cross the joint this way, and the soleus, or not soleus, the gastrocnemius crosses that way. So it's a very strong fibrous interconnection. Following that up, it ties right into the ischial tuberosity, which is your sit bone, and right into the dorsal sacral ligament. As we follow that up, it goes into this area, the sacral lumbar fascia. This is very dense, thick connective tissue up into the erector.
This is the thickest fascia of the body. So when it's shortened from a bad posture, bad mattress, long sitting position, it actually shortens and it squishes your spine against each other. And then the spine, when it's squished against each other, it actually herniates the disc. So that's why there is spontaneous disc regression with myofascial release techniques that will make like there is 50 study papers that were done for spontaneous disc regression after 18 to 24 months of therapy for the neck area and for the lumbar area. So it is not irreversible, it is reversible, but we need to remove the mechanical compression. Usually sometimes when people do surgeries, they have to redo surgeries afterwards, or they do have relapses or stuff, or they have to do fascia manipulations in order to reverse the scar tissue that is done from the surgery.
Spinal muscles. Now these are the long muscles that travel the whole length of the spine, they're like cables. But not only does the fascia.
So the erectospinae muscle, if you all remember, it came off our thoracolumbar area. So it starts with the multifidus over here, and then it's gonna fan. It's called like I love spaghetti or iliocostalis, and then longissimus, and then spinalis. It's like a fan. Okay, so his summarizing it in only this area, but you can know that this muscle is actually one sheet that's split it into three parts. We were, so it's even deep breathing can help with low back pain because you are tackling the lateral fibers of the erector spinae group, which is the iliocostalis over here. So you can ease this part and stretch your thoracolumbar fascia by deep breathing techniques, some stretching postures, and so forth.
Into these muscles, it penetrates deep into the transversospinalis muscles. So once again, the continuity is quite incredible because it's penetrating various levels, maintaining a nice continuity all the way up. When we get to this point, it ties right into the musculature in the back of the neck, below the skull here, the suboccipitals. And at this point, it ties right into the fascia of the scalp, the galena aponeurotica, which comes across the back and top like a cap, tying into the frontal bone.
This is the occipital
So when we're looking at the
frontalis.
superficial back line, it's one continuous fascial plane. In other words, it's part of your kinetic chain. Everything is interconnected from the bottom of the foot into the heel, all the way up to the front of the skull.
Okay, now that we have a few acupuncture points on the body, I put a number along what we call the bladder meridian. Now, it's really important to note the relationships between the fascial plane or kinetic chain and the bladder meridian. So we've got a number of points here, and you'll notice that they're in close proximity to where the tape is. Now, the meridian itself actually overlies right on top of these fascial planes, which is really interesting, especially when you look at some specific points. Now, you may look at a point and you say, well, okay, how close do I have to be to that point to actually get a reaction? Not that close. There's some interesting research that's come out. If we look at it, and we look at a German study that was done, for example, it was quite extensive on 1,000 different people. And they took one group and they did true acupuncture, or acupuncture, and they also did one sham acupuncture. What's interesting is the sham acupuncture was actually placed on the points but in close proximity to the point. So even though it was still not.
So the sham acupuncture is they pretend they have a needle, but this needle retracts to inside instead of getting into the skin of the person. So it doesn't create the same effect of acupuncture. So it is called sham acupuncture, and they do it for control studies with in the Chinese medical acupuncture. They do sham to do control cases.
On the classical point, it was still on the fascial plane. And they also,
it's like people who receive placebo in medicine.
Another group, kind of as a control group, where they basically just used to see if they could get a placebo effect. Now, they found really good results with both the sham group and the true group, which was interesting, which means that something is going on at a neurological level. This wasn't even close to placebo, so even a couple of years past this point, they'd see really big changes. Now, let's take a look at these individual points and just see what I'm talking about when I say each of these points can affect things on the kinetic chain on the fascial plane. Now, as I said, the bladder meridian is sitting right on top of the line I drew around here, which is the superficial back line. Now,
so bladder meridian, because it goes where the kidneys are, which is our bladder, and people who have kidney surgeries, they're actually going to experience back pain, knee pain, and stuff like that as well. So any meridian that they say in the Chinese medicine actually passes through the organ that it is named with. Like for example, if we say the liver meridian, that means this meridian passes through the liver. Like, so that's why they named it with this organ. Heart meridian, it goes through the heart. So this one goes through the bladder. That's why it's called the bladder meridian.
Let's look at these points. We say, okay, I've got a point up here, and this is bladder number 11. Now, it's interesting we look at this point because we say, okay, this is up on the shoulder. Now, when we talk about kinetic chain relationships, we're always saying how tension in one area will affect another area. We've got a tight, restricted shoulder. It can cause neck pain. Neck pain will change the position and the tension that happens in terms of the base of the skull, kind of pull it back a little bit. This could create headaches and all sorts of problems there. So they would use this point for not just the localized area in the shoulder, but so it would affect the entire head. Quite interesting. We're going to move down a little bit here. And we get into the part of the lumbar spine down here, right across the L5. This is bladder number 23 point on the bladder meridian. If we look at that point, it's not just used for pain in this area, but the entire area up and down. And it affects a wider area on the whole fascial plane. Move down a bit. you get behind the knee, and we say, okay, this point right here is kind of over top of a muscle called popliteus. Now, this particular point here could be used for problems in the lumbar spine. So in other words, we've got a point that's quite distant, and yet it's on a kinetic chain. It's on an area where we have fascial relationships. We look at it and we say, okay, we know very well the calf muscles connect and the hamstrings connect, and then it basically connects into the low back and the fascia here. Taking tension off of this area here will actually create a positive effect in that area here. Now, we can either take tension off through, it could be massage, it could be active release, it could be a wide variety of different types of therapeutic modalities, or acupuncture itself, and we still get the same result. Move down a bit, and it's really interesting. This is bladder number 55, similar effect to the low back. Move down to the ankle here. Now, this particular point here, bladder number 59. What's interesting about this is they actually use this for headaches. So how could this possibly create an effect on top of the head there? There has to be some kind of a neurological response taking place. Same thing, bladder number 64 on the foot here. That's also used for headaches. And you say, well, how could this possibly happen here? If we consider how acupuncture is done, we take a needle, we put it into a specific area, and then we stimulate it, we turn it. And as we turn it, we start to feel a little bit of a tug on there. And we say, okay, unless there's some resistance on it. This is actually called a tug response. And they actually have little robots they can actually use to measure the amount of tension on that needle, which is quite interesting because even though you put the needle in and you leave it there for half an hour or 40 minutes, you still basically have a tension on that or a tug being created on that, which does not diminish with time. Now, that actually causes a stretch throughout the area, and that stretch has both neurological and circulatory effects. So we're treating something down here, and yet that's affecting the entire kinetic chain all the way to the top of the head.
So I'm gonna cut it here. It's a very interesting video, and I had a couple of more videos, but I'm not gonna be able to do it today. But you can see one of our sessions for knee pain can basically tackle this line. When we do stretches, we can also tackle this line, especially with people who are having a problem with this line when we do the assessment. So if they have this shortened, if they have one leg more than the other, some people like, especially moms other than people who work on the computer for a long time and drivers, moms who were just nursing, like they just finished their lactation for the baby. They usually lean on one breast side more than the other. So they have post-nursing scoliosis. So a little bit of a curvature over here is going to be, you're going to find a fold on one of the sides of her waist more than the other. So you need to do some work over here, even if she's experiencing pain on one side of the body because her weight is shifted to this side of the body more than the other. This is very important to consider, like consider the lines, consider where the pain is coming from, see what caused the pain, how was first experienced, when did this happen. Sometimes it happens after emotional trauma, sometimes it happens after an accident, driving accident and stuff like that. I'm gonna skip through the videos because we don't need this is, for example, lateral line. You can see how this, I'm not gonna make play for that line, but I want you to see how it is going to fuse with the IT band over here. And also for people who have scoliosis, it's going to be in one side shorter than the other. So we need to work both lines on the same thing. And it actually goes all the way here. So somebody can experience a little bit of ringing of the ear. They can experience tumors over here or something. And all what you need to do is work on their lateral line because this is where they have a problem, especially people who always lie on one side and read a book or something like that. They're going to always have a difference between the right and left lateral lines. So this is for that, and I'll just get this up a little bit. These are the muscular connections, and if you just saw like anatomy trains, they have a lot of courses online that you can actually sign up for. And yeah, so let us go to another slide. So this is the IT band, and it shows you a little bit of stretches over here. I can also send you this if you want, inshallah. And the last thing is, what do? We do functional assessment. We do holistic therapy. So we speak with the person as a whole, not as a muscle, as a knee, as a shoulder. No, we always say it's a complete system that assists each other. We have the knee front, back, like medial side, lateral side. The inside of the knee is always a problem because of us sitting on a chair for a long time. That makes our adductors much shorter than our abductors. We have to know if this person is driving for a long time, he is sitting for a long time, what is his nature of job, what his level of education. And then we try to combine, like, stretching, acupuncture, dry needling, cupping, so many things, even gua sha stones. Okay, so healing yourself is connected with healing others. Usually, when people are dismissed out of your service because they feel better, they felt strong, independent, they empowered to get control over their own body, and they don't come back to you, they will usually send their friends. So I had some doctors posting in their social media, one patient cured, one customer lost. This is complete nonsense. Everyone that's cured, Allah heals your body as well. Like, I have so many people that I do for, like, cancer treatment and stuff like that for free. Once they're done, I feel like I took the session myself. Wallahi, subhanallah. So this is question and answer. I'm gonna stop the recording, and I hope everyone like benefited. I wanted to say much more, but the time is limited. And I'm happy everyone joined today. I will stop the recording and open it up for questions and answers. And thank you. So stop.